So today's first session at MyKE and Amgen organized meeting in Barcelona was dedicated to three main topics that are important issues, important part of the way we take care of patients with multiple myeloma outside of the context of treatment that will be more covered tomorrow. On day 2. So three essential parts of the way we diagnose myeloma and the issues we face. Number one is patients are treated and the survival, the benefit the patient get from the patient depends on risk features, high risk features, how we used to put it, or standard risk features. And upon treatment, some patients will massively decrease their tumor burdens, while other patients will decrease their tumor burden, but it's a much lesser extent. And so we call it minimal residual disease. And so the first topic was about these two pieces of understanding the prognostication of the patient. So Bruno Paiva from Pamplona, Spain, participating on behalf of the PETEMA group, the Spanish myeloma group, gave us a talk on definition of high-risk features. And he very nicely introduced the fact that today you must still use a scoring system called revised ISS, which includes ISS, a part of the genomic abnormalities from the tumor cells, and a serum test called LDH, lactate dehydrogenase. These three group of tests, LDH, genomic, and a beta-thermoglobulin plus albumin ISS score, makes the revised ISS. And if you are revised ISS 3, you're in high-risk feature myeloma. He also talked about the fact that on its own, it's not sufficient. There has been multiple other abnormalities that have been added to the revised SS3 system to improve the definition of high risk. Most of the tests are organized around the genomic abnormalities of the tumor cells. In the revised SS3, it's mostly about translocation 414 and or deletion 17p, but other tests, other abnormalities are now of importance and should be considered and looked into at the time you diagnose the patient and probably in the relapse setting as well. And that includes other abnormalities. He talked about 14, 16. This is more discussion, but 1p, 1q issues, and certainly the fact that some of the patients with deletion 17p or some of the patients with revised ISS3 have an ultra high risk dismal prognostic with more complex abnormalities. So that takes us to high risk definition versus standard risk. In the high risk definition, a group of patients ultra high risk. The ultra high risk most of the time die within, still today with all the drugs we have access to, die within 2 to 3 years in median. And for the high risk, most of the patients will still die within 5, 7 years at best with all the drugs we have access to these days. So really, we have improved for this patient, but we are really far away from what we get for the standard risk. Because on the other side, of the flip side of the coin, as you guys say, there is a standard risk group which truly has incredibly improved in terms of survival, but the high risk, it remains extremely complex. So Bruno touched upon other issues about other profile, myeloma profile that could be associated to high risk, plasma cell leukemia, plasmablastic features, extramedullary disease, etc. That at some point we're going to have to add to the high risk group in a sort of global scoring system if we can. Then he switched gear to the other part of his expertise, which is now that you have the risk features at initiation before you start the treatment. Now the patient get treated, and upon treatment, some of the patient will not or poorly respond, while some of the patient will incredibly massively debulk. to the point of what we call minimal residual disease. And so he discussed various issues regarding what best technique, is there a better technique, two main techniques, next generation flow, next generation sequencing, and we all agree that the two techniques are very important, very informative, probably very useful at a level of 10 to minus 5 or 10 to minus 6 for the study of MD. And that then you use a technique you probably can handle best in your country or in your center. We discussed the fact that probably you would start looking into MD when you reach VGPR or CR, and probably every 6 months, once a year, because as it has been pointed out by one of the attendees in the audience, Professor Heinz Ludwig, the question of reaching MD at one time point, it's not sufficient to consider that we already reach a level of very good prognostic in terms of PFS and overall survival. You have to have a maintained MD over time, if at least in repeated time points, if you really want the MD to be of great interest for the patients. And really mimic the improved and significantly prolonged PFS and overall survival. So Bruno Paiva discussed this. Then, because we were going through a case to kind of put the speakers into a context, we then discussed in the case I was leading, we then discussed the bone myeloma disease, or myeloma bone disease, MBD. We have an incredibly increased number of patients which are diagnosed without any myeloma bone issue these days, because they are diagnosed very early on, often because they were diagnosed as a pre-malignant stage, MGUS, or at the already malignant stage, smoldering myeloma, but not yet symptomatic, so we were able to treat the patient slightly earlier to avoid the patient from developing myeloma bone disease. That's more and more frequent in our practice, probably worldwide. However, we still have a lot of patients that are diagnosed with a lot of myeloma consequences on the bone skeleton. There are two types of issues, the cortical bone or the trabecular bone. The cortical bone is the outside part, and the trabecular bone is a part inside the bone marrow that kind of serve as a carpet, let's put it this way, for the marrow to sit there. And so you could develop myeloma bone disease. The bone is destroyed by hyperosteoclastic activity and a massive decrease in the osteoblastic activity. So not only you have more resorption, but on top you have a complete disappearance of the cells that try to reconstruct the bone. So you really have like a massive instability in the bone structure. This was known for very long time. We have had in recent years more insight on the biology, how it works, but most importantly, because we had access to drugs, especially for a long time we had the bisphosphonate to kind of limit the resorptive activity while we are trying to control the myeloma disease. But recently, Amgen was able to develop a new generation of anti-resorptive drugs from learning from the biology of the osteoclast, which is the expression of the RANK ligand molecule, and the so-called RANK ligand osteoprotegerine RANK pathway that sees the RANK ligand being massively expressed and the osteoclast being massively activated. And so they have developed denosumab, an anti-RANK ligand antibody that sort of block the RANK ligand activity, limit the osteoclast activity. And Dr. Chantry from Sheffield, UK, beautifully explained to us the benefit of denosumab, the difference from denosumab to the bisphosphonate. Why would denosumab really be a progress compared to bisphosphonates? And how should we be using these drugs for the myeloma bone disease control? And then finally, going through the case, we discussed a third and last issue that we tend to face probably much less now in myeloma, which is the neurological issue that sometimes is related to the disease or to pre-existing other cause of neurological issues. But since the development of bortezomib, the first-in-class proteasome inhibitor, Velcade, we've had a lot of neurological issues associated to Velcade being a neurotoxic drug, and also to other Velcade combinations based drugs like thalidomide that also was in a different mechanism of action, but also was a neurotoxic drug. So Professor Griswold from Vienna, Austria, is a neurologist. He touched upon the, first of all, different type of neurological disorders you would have before the diagnosis, or could take you to the diagnosis of some gammopathy, either malignant or not, depending on the isotype of the M spike, IgM, more anti-MAG, while if you are IgA or IgG, a different type of neuropathy. So he discussed this. He discussed the importance of learning from the prior story of the patients, because patients with some treatments, some diabetes, and other issues, arthrosis from the spine, etc., could actually have a neurological issue which has nothing to do with the gammopathy, and sometimes could be miscomprehensive and misunderstood in who's responsible to what. So he discussed this. He discussed the importance of running test for velocity, electroneurophysiological test in looking at the velocity of the nerve conduction, because this will lead you to understand a lot on whether you have an axonal issue or other type of issues. You still have to remember that you may have amyloidosis, and that brings you to specific test and potentially a biopsy. And so Professor Griswold discussed in the end of his talk what would be the best anti-pain killer, which would be the painkiller for neurological pain, which is very different from bone pain. And most of the bone painkillers actually have very poor effect on neurological pain. And often what we do is that we increase the dose, and the patients suffer more actually in the end from the side effects and from real effect. So he discussed the importance of pregabalin and bengapentine being the first neurological painkillers you should be using, but always, and he has been very, very specifically repeated this, always be very informative to the patient that the effect from one patient to the other could vary a lot. Some patient benefiting a lot, and some patient benefiting very mildly. And sometimes some patient could benefit like very rapidly, but for some of the patient it could take months before they see a benefit to it. So we discussed this. So in the end, we had a Q&A part of the talk, of the session, where there has been a lot of course, questions on MD and how should MD be performed, and when should it be performed, and also the fact that when you look at MD at one spot, you think that what the result you would get, let's say, in the sternum here, would be an clean representation of what you get for the whole body. And in fact, we know in myeloma that this is possibly true for some patients, but absolutely not true for other patients, which is why we have developed, and the Italians and my group in France, Intergroup for Multiple Myeloma, we've been quite pioneer on this one. We have developed this sort of PET-CT plus marrow MD assessment. Marrow really looking at the cell at one spot, while the PET-CT looking at the hypermetabolism of the tumor cells, but globally for the whole body. And if you combine the two, it seems to be a quite strong prognostic appreciation of what is MD. There's been a question on also, which is I think is very important, on should we run MD tomorrow morning in real life? The answer is no, not yet. There will be a lot of studies, clinical trials, starting globally, worldwide, and I can tell you that there are plenty in Europe, that will look into, okay, MD is prognostication. If you remain MD positive, you are not good risk anymore. If you turn MD negative, you significantly improve your risk factors. But should we change the treatment? Should we tailor treatment on MD? So because you're MD positive, we would give you more treatment, or potentially vice versa. If you are MD negative, we could de-escalate and give you less treatment. This is really not at all ready to provide any answer to this specific question. So it was a very lively, I think it was a very lively session when we learned a lot about, again, prognostication, bone disease, and neurological issues that we tend to see with the patients.